All right, everyone, welcome back to another episode of Insights of All Trades. If you're watching the video, you can see that we're on Zoom again, so this is our second Zoom conversation, and I do not have Nick with me today. I think he's driving to DC right now to pick up his brother, so decided to solo this one out with one of my professors from Wilkes, Dr. Stephen Kheloussi. But before I get into giving a little introduction about that conversation, I'll go through our normal intro segments here, and we'll start with our quote that we dissect. And that quote is this, and it will make a little more sense in the context of the conversation we have when we get to the podcast. Bad news travels fast. Good news takes the scenic route, which is a quote from Doug Larson. So to foreshadow a little bit of the conversation we have today with Dr. Kheloussi, we kind of try to deconstruct, or at the very least demystify, the U.S. healthcare system, all of the players in it, some proposed problems and more proposed solutions to said problems. And within all of that, a lot of people can be quick to think about all of the bad things they heard in the news, from insurance to drug manufacturers or quote unquote big pharma, or possibly PBMs or pharmacy benefit managers, if you've heard of them, what they do and how or how not they may be bad actors. So we get into those things, and I think that's a good quote to keep in the back of your head. Also, before we get started, we want to give a special shout out to our sponsor, Riggin It Gear. So as you all know, Jacob Younger, who started Riggin It Gear, started his pack company after through hiking the Appalachian Trail last year. If you haven't listened to that episode yet, with Jacob kind of talking about how he through hiked the AT using some of his own gear that he put together, and used that kind of as the stepping stone to starting his own pack company. Definitely give that episode, a good check out, a good listen through. And I believe that is all of our intro stuff. We checked off all the boxes there, and now just to give you a little touch on what we talk about today. So my guest, Dr. Stephen Kheloussi, he's a professor here at Wilkes, and he also works as a managed care pharmacist at Geisinger Health Plan. So we talk a little bit right away in the beginning about what that means, and then we move into a little progression on when you show up at the pharmacy counter as a patient, or wherever you get your medications, whether it's mail order pharmacy or, whether we're talking about bills at the hospital, which is kind of a separate conversation that's not quite as closely aligned with the one we have today. How do those prices show up? And it sounds like a very simple question, but there's a lot of details and a lot of nuances, and that kind of segues into the rest of our conversations we have today. For sure, the conversation is pretty information heavy by default, talking about the healthcare system for any country, especially within the US. There's a lot of things, a lot of actors, a lot of industries behind the scenes, and it can be pretty burdensome to try to take it all in one listen through. So this might be one of those podcasts that is best listened to in segments, or you might have to re-listen to some things, because even though we do our best, and Dr. Kheloussi does a really good job trying to break things down that are very nuanced, that being said, I still think it could necessitate for me, at the very least, going back, giving another listen through to make sure I really picked up some of the details that he was putting out there. And then towards the end of the conversation, we kind of get into, if we can't change the healthcare system immediately, which I don't think anyone, me including, can snap their fingers and make it change right away, what are some good insights that we can take away to, say we're looking for our own health insurance plan, or we're trying to optimize the one we have now? What are some good takeaways that, moving forward, we can have in the back of our mind as we're trying to optimize our health insurance plan? So without further ado, please enjoy this episode. Welcome to Insights of All Trades podcast with Nick and Cole. This is where we talk with people we meet along our journeys through medicine, military service, sports, education, and beyond. We hope you enjoy. I'm here with Dr. Steve Kheloussi. How's it going?
Very good. Very good. How are you?
Really good. So we're both doing this from our homes in quarantine right now, and this is actually our second Zoom podcast. So forgive us, listeners or video watchers, for any minor glitches. We're going to try to tough it out here, but the first one we did ran pretty smoothly, so I think this will go, pretty similarly.
So you're saying if we mess up, it's my fault then?
Of course, put all of the blame on Dr. Kheloussi. First and foremost, I just want to thank you for making time to come on. I know your schedule is a lot more demanding than mine, as I kind of sit and goof off in my bedroom all day.
No, yeah, it's my pleasure. I'm always happy to take the time.
So we'll do the intro and stuff afterwards, so I won't burden people with your long list of managed care accolades. But just to put it in your words and not mine, when you talk about what it means to be a managed care pharmacist, what does that mean?
Yeah, so it's a very common question that I get. So, as the instructor at Wilkes University, where I focus on managed care as my primary, mode of teaching. A lot of students say, I don't know what that is. I'm not interested in it. And it's, really a foreign concept for a lot of people. But it's really the behind the scenes payment side of healthcare. So it's insurance companies, it's pharmacy benefit managers, which are basically third party companies that work for insurance companies and employers. It's kind of the link between, how we get drugs to patients and how we figure out how we're going to pay for those drugs. So that's the very high level overview.
So taking that high level overview and going into what should be a simple question, but as you and I both know, this will unfold a bunch of complexities and nuances. So when a patient shows up at the pharmacy and they have their medication, and we'll presume here that they have some sort of insurance, whether it's Medicare or Medicaid, or if they have some sort of private plan, can you kind of walk us through, as long as it takes, of course, how that price that the patient pays for at the pharmacy counter, how that gets there?
Yeah, it seems like it should be a simple question, Cole. You're right about that, but it's the exact opposite, which is why we need managed care pharmacists galore nowadays. So when you buy like a normal product, something over the counter like a soda or a bag of chips or something like that. In your case, I think it'd be more like protein shakes or something like that, right?
Yeah, along those lines.
So when you buy a protein shake over the counter, you end up paying basically the price that the manufacturer sets plus a slight markup for whatever the store wants to make in profit, right? And so if you go from one store to another, you'll pay a different amount because the manufacturer sets it at one price, but store A charges a little bit more than store B just because they need to make that extra profit on that particular good, whatever the case is. If you're talking about prescription drugs, there's a whole bunch of intermediaries that lead to some complexity. So first off, we have the pharmaceutical manufacturer who sets one price. And then you have a wholesaler who is basically a middleman between what's the word I'm looking for? The pharmaceutical manufacturer, the industry, basically,
right,
as they're called, pharma, if you will. So the wholesaler is the middleman between pharma and the pharmacy. And basically what the wholesaler does is they buy a whole large stock of the drug, keep it on their shelves so that the individual pharmaceutical manufacturers don't have to worry about selling their product to each individual pharmacy. That would be a logistical nightmare. So then at that point, the wholesaler has the drug in their possession. They paid one price from the manufacturer to buy that drug, and now they need to resell it to a pharmacy, and they also need to make some profit on that. So the pharmacy buys the drug from the wholesaler, and then they have to mark it up in order to get that drug to the patient and make some profit on that as well. So there's a price that the wholesaler pays, there's a price that the pharmacy pays, there's a price then that the patient pays. So there's a whole number of different prices that can be paid. And when you introduce insurance into that, it gets even more complicated because now the insurance is saying, pharmacy, you can't be billing us for, these obscure prices that you're expecting us to pay, because realistically, we know that you're not buying the drug for that much money from the wholesaler, or at least you shouldn't be. If you are, then you need to rework your contract. So when you have all of these different players, you end up having a lot of different contracts in place, and those contracts are really what ultimately determines how much a patient's going to pay. So there's contracts between the wholesaler and the pharmaceutical manufacturer. There's contracts between the pharmacy and the wholesaler, contracts between the pharmacy and the insurance company, and then there's a contract between the patient and the insurance company, basically to determine how much that patient's going to be paying with their copays and all of that. So it gets even more complicated when you introduce pharmacy benefit managers, who are a middleman in between the pharmaceutical insurance companies and the pharmacies. And so, with all of these extra components, it becomes very opaque how much a patient or how much a drug is actually costing. So it's not that, you buy that that bag of chips from, let's say Lay's, the manufacturer, and then, you know exactly how much you paid for it. And now all of a sudden you can sell it for that amount. Now you have to consider, how much did the wholesaler pay? How much did the pharmacy negotiate? How much does the contract between the pharmacy and the health plan and the pharmacy and the pharmacy benefit manager? All of these numbers all sort of convolute the price. So there's a lot of different prices that can be paid, and when you take all of that into account, it leads to really unusual situations where you can have two people in the exact same pharmacy with the exact same insurance getting the exact same drug, and they're going to pay two different prices.
Yeah, that brings a lot of intricacies up. And of course, I'm not as well versed in the space as you or other managed care pharmacists. So when my friends who aren't necessarily in the pharmacy community or in the medical community ask me why their medication is X or Y price, or why their grandparents are paying outrageous prices when they were paying $20 last month, what is happening there? And I wish I could give a 20-second black and white answer, but there's a lot of intricacies there and a lot of cross interactions between the PBMs and the pharmacy and the insurance company, as you mentioned there. I want to pause for a moment at the PBMs, who you kind of introduced as this almost mysterious third-party player behind the scenes that, again, people outside the pharmacy community might not really pay attention to. Can you give me some examples of some possible concrete roles they can play?
Yeah, absolutely. So a pharmacy benefit manager, I called them a middleman. If you think of the term middleman, it typically has a negative connotation to it. And when you, I see you're smiling because, when you read about PBMs in the news, all you see is negative information out there. And, there's a lot of things that PBMs do well, but there's a lot of things that do bring a lot of scrutiny as well. So when you think of medical billing right now, and, the patient goes to a hospital and they're treated, and then they go home, they have no idea how much they are going to owe. And that is a problem. That's a major problem. And surprise billing is something that even the government is kind of catching on to nowadays. So in order to get away from surprise billing with pharmacy drugs, and there's a reason I call them pharmacy drugs versus medical drugs. There's a difference, weirdly, that we can talk about more later on if you'd like. But when you're considering, drugs that a patient picks up at the pharmacy, if they were to receive their bill 3 months later, they might be caught off guard by the cost of that drug, right? On top of that, they may have already refilled that drug several times. And so, there's a distinct need with prescription medications for patients to know exactly what they're going to pay at the point of service when they go to pick that medication up, so they can make an educated decision if they actually want to get that medication or not. So pharmacy benefit managers sort of came into existence to fill that role. So when you have a number of insurance companies and you have a number of pharmacies, thousands and thousands of pharmacies and hundreds of insurance companies across the United States, all of these companies need to talk to each other. And so in order to prevent, paper billing that takes several months, you write down an invoice. Oh, I got a prescription for, drug X and I filled this quantity of it. And then you send that to the insurance company and then they get back to you in 3 months. And then they say, all right, you have to, charge the patient this amount. It doesn't work. It just would never work. So PBMs came into existence to really, speed up that, they call it the adjudication process. So when, the pharmacist or the pharmacy intern in your case, or, whoever it is at the pharmacy technician even, is billing the insurance, what they're doing is they're actually sending information to the pharmacy benefit manager, and the pharmacy benefit manager then compares the patient's benefits to whatever the patient's insurance benefits to whatever prescription is being requested, whatever quantity is being requested, and so on. And it basically, all their algorithms that they have behind the scenes connect those and say, all right, this is what the patient is going to owe right now. This is what the pharmacy is going to get paid right now. And after that, then, the transaction can continue as any normal transaction would. With, medical drugs that are given by healthcare providers, or with medical services, if you had that sort of system in place, patients would be able to make a decision. You know what? I don't know that I can afford this $50,000 surgery right now. I don't think I'm going to get it. And so, it becomes a lot more complex when you start thinking, while this system is really good and it helps a lot of people understand the costs that they're going to be paying, it unfortunately also ends up leading to a lot of, decisions on healthcare that are being made on cost, which is not necessarily appropriate either.
Right, which is why when we always begin our lectures in managed care, or when I was at your site, it seems that you really make an emphasis on, first, we're going to make a drug decision based on efficacy and safety, and then if all other things are equal, we'll begin to make a decision based on cost.
Exactly, and that's the problem with patients making decisions based on cost, is that they don't consider, not all the time. So many times patients don't consider the benefit that this drug, for instance, is going to bring them. They just see the cost at the pharmacy, and then they'll say, "No, I'm not going to pick that up. I'll worry about my diabetes when it gets worse," or I'm not in that much pain right now, so I'm not going to fill this medication right now. And that's perfectly fine. I mean, that's their decision to make. But the problem is that when you focus on, what's the proper term I'm looking for? You focus on fixing a problem that already exists rather than preventing a problem. That becomes, a sort of a slippery slope. So,
yeah, and probably more costly in the long run.
Exactly. So, I mean, with, hepatitis C, those drugs got a lot of attention a couple of years ago when they first came out because they were so incredibly expensive. That wasn't really the price patients were paying, but some patients who didn't have, good insurance, they couldn't afford the $100,000 that these drugs were going to cost. And so they said, all right, well, my hepatitis C is just going to have to wait. And if you don't cure hepatitis C early enough, it's going to lead to some irreversible problems. And, the patients then are going to have to pay, significantly more if they have to go in and get a liver transplant, even if it's not a financial cost that they're, going to be burdened with. It's the complications that end up costing a lot more in the long run. So
still picking your mind a little here about the PBMs, on top of them being a middleman in what you call the adjudication process, with the price submission claims might be the easiest way for me to conceptualize it.
Sure.
There's some other roles they play, and I'm still thinking of we'll call them benign and not what they're getting ridiculed for in the news, which I do want to get to. From what I understand, some of them, not all of them, also act as their own wholesalers, correct?
Yeah, so I think it's this is a very complicated topic of what's called vertical integration. And so this has been occurring a lot over the past few years where, major players within the healthcare system are sort of merging together and creating almost conglomerates in a way that are going to control multiple aspects of the healthcare system. So whereas a pharmacy benefit manager on its own historically, it had, amongst the role that I previously discussed, a number of other functions. If you then combine the power of a pharmacy benefit manager like Caremark, and you combine that with CVS Health or CVS at the time, and you create CVS Health, which then entails a mail order pharmacy, a pharmacy benefit manager, and a giant retail chain. Now you have a very large conglomerate. Add on top of that when CVS and Aetna merged, and now you have the three pieces we already talked about and a health insurer. And so while they're not necessarily their own wholesalers per se, they're taking such a large part of the healthcare industry that they can very easily gobble up one of the wholesalers and become their own wholesaler if that's what they really wanted to do.
Would that maybe be why, and maybe this is more black and white to you, but I'm kind of just putting the pieces together as I think about this, why some insurance companies are telling patients, hey, we're only going to fill this mail order because then it comes from, that PBM's mail order pharmacy and kind of saves them some money as well.
Yeah, so this is a rabbit hole if we want to get down it. I'm happy
Let's
to.
do it.
So mail order is historically has a bad rep, of course, just because patients like their community pharmacies, generally speaking, and so forth. But the undeniable fact about mail order is that it is more efficient than a retail pharmacy. Yes, we lose a lot of that face-to-face communication, and that hurts the patient aspect. But from a dollars and cents perspective, if you can fill one prescription for a 90-day supply, and you can fill, I'm just throwing out here a number, if you can fill 1,000 prescriptions an hour versus your community pharmacy that can only fill, let's say, 40, it's just naturally less efficient to, pay that community pharmacy to do that work. On top of that, those community pharmacies need to charge a higher rate, basically, to staff the pharmacy and so forth, as compared to a mail order pharmacy, which can just churn out prescriptions much more efficiently. So, from a health insurer and a PBM perspective, there will be a lower cost of filling a prescription if you use a more efficient method of filling that prescription. So, health insurers and PBMs over the past probably 15 years or so have recognized this, and they've said that, we are not going to, it started initially as we're not going to force people to go to mail order, right? Because we want them to have choice. Just in general, patients like to have choice. Patients don't want to be told which doctor to go to, which hospital to go to, and patients pay a little bit more to do that. But then what was happening was patients were choosing the less efficient route, and they were going to their community pharmacies, and they were, still filling at the more expensive location. And so what ended up happening is that a lot of insurers took one of two approaches. They said, either we are going to force patients to go to mail order, which again, patients didn't like that because they like choice, or we will incentivize them to go to mail order. And so if they, fill at mail order, we'll give them a 3-month supply for 2 copays, versus if they go to a community pharmacy, then they'll pay 3 copays for a 90-day supply, and 3 30-day copays, I should clarify. So in a way, there's that incentive that pushes a lot of people who are saying, I fill the same medication every single month. I don't really have a reason to go into the pharmacy to talk to the pharmacist about it every single time. Mail order works for me. It'll be less costly. Whereas you have the other patients who, are starting a new medication, and, maybe their insurance plan is saying you have to go to mail order. They might want to get that initial counseling from their community pharmacist. They may have a relationship with their community pharmacist, and they may feel like, their plan is betraying them in a way that they can't go where they want to go anymore. And so All sorts of insurance design strategies around that. Either incentivizing or more forcing patients to go that way. And each patient, when they sign up for their insurance plan, will be able to sort of, determine which way the plan is going to be directing them ultimately.
When we say that, it's saving costs, and don't mistake me here for being an evangelist for mail order pharmacies or anything, but is that because the dispensing errors with mail order pharmacies are, from what I've heard, like magnitudes of 10 lower than dispensing errors that happen at a community pharmacy?
That I can't speak to, unfortunately. I don't have any specific statistics that will support that one way or the other. Generally speaking, if you have an automated process, that will cut down on the risk of filling errors. But there's still a lot of manual work with mail order pharmacies, such as entering prescriptions and verifying prescriptions, verifying that they were filled correctly, and somebody has to fill up those robots with medication. So if there is still the potential for mistakes on mail order side. So I can't speak to that for certain to say that there is less of a risk for errors, and that's what cuts down on costs. I think one of the biggest things that cuts down on cost is that many of these mail order facilities are owned by the pharmacy benefit managers or the health insurance companies. And so what that means is that, would you rather pay somebody else to do the same thing that you can do more efficiently? And so when you sort of pose the question that way, it kind of gets to the bottom line of, when you are making these contracts between different players within the healthcare system, you have to kind of understand that it's always cheaper to pay yourself than it is to pay somebody else. And so CVS Health, for instance, not to pinpoint, they're just one of the largest in the country, and so we can use them as an example. But they, for instance, have the opportunity, and I can't say for certain that this is what they do, but they have the opportunity to pay themselves through their mail order pharmacy less than, or even through their retail pharmacy, a lower reimbursement rate per prescription, because the money is all sort of staying in-house, versus if that patient went to, a Walgreens pharmacy or a Walmart pharmacy or something like that. So, when they're negotiating those contracts, oftentimes they're held to the same standard as those outside contracts. So, multiple companies owned by one large, conglomerate, for instance, is not necessarily going to be treated differently, but they might get more favorable, reimbursement rates and so forth.
Sounds good. So if we accept this argument, which I do, that at least on the surface, at face value, it seems like we're saving a lot of money, and possibly, depending on what the statistics look like, through tasks like, not tasks, but through systems like mail order pharmacies, and by automating a lot of otherwise humanly performed dispensing tasks like text counting the medications, and pharmacists in the community pharmacy verifying it, just by taking a glance in the bottle and putting the pills in their hand. So
there's a lot more to it than that, for the record.
For sure. I am grossly oversimplifying it. But if we accept at very minimum that there's some good benefits, why in the news do we see pharmacy benefit managers like CVS Caremark, for example, being made out to be a possibly bad player? Is there any logical argument to that?
Sure. I mean, there's so first off, there's a very interesting podcast from the writers of Freakonomics that I encourage you to listen to, and about the news, basically that good news doesn't sell, which I found very interesting. And so that's number one, right? I mean, if you're doing something good, you often don't make the news. The other aspect of it is that I think the PBM industry historically has sort of been shrouded in mystery. that, the contracts were very opaque. There was something called clawbacks that recently came out that we can talk a little bit more about if we want to continue to bash the PBM industry, which I absolutely don't, for the record. I think they do a lot of really good work, and the services that they offer are absolutely necessary. It's just the way that that many PBMs were kind of going about their business, caught the attention of consumers, and then subsequently the attention of the news, and that's sort of what played out in the media more so than anything else. So there's still a lot of scrutiny of the PBM industry, and Supreme Court cases and so forth that are coming up. But the big aspect of it is that a lot of community pharmacies feel that they are being shorted in terms of reimbursement by PBMs, because the PBMs are the ones who, generally speaking, again, not 100%, PBMs generally will negotiate contracts on behalf of health insurance companies. And so the health insurance company hires the PBM goes out to each individual pharmacy, and these companies, being as large as they are, they have a lot of negotiating power. And so, if we look at the two major companies, Express Scripts and CVS Health, right? If we take into account those, they account for more than 75% of all of the prescriptions filled in the United States. They cover something in the hundreds of millions of lives. And so that sort of negotiating power, when you go to a pharmacy that's a small mom and pop pharmacy, and that massive company says, look, if you don't accept our, and again, I never did negotiating on behalf of a PBM, but this is how sort of I imagine the conversation goes. If you don't accept the rates that we are proposing, then none of our 90 million or 100 million lives will come to your pharmacy. And that really puts these smaller independent pharmacies at a disadvantage. So when you have a really large pharmacy chain like Walgreens, for instance, who has several thousand pharmacies across the United States. I don't remember the specific numbers off the top of my head. I apologize. But if they were to go to a negotiating table with Express Scripts, which is actually something that occurred, I'll talk more about that in just a second, they have a lot more negotiating power. And so back in 2012, there was this feud between Walgreens and Express Scripts, and more recently between, I believe it was CVS and Walmart, where these really large companies are just sort of headbutting each other and saying, look, if Walmart doesn't accept CVS's rates, then none of CVS health insured patients will go to Walmart pharmacies. And Walmart comes back and says, well, if you don't accept our rates, then none of your patients can use any of our pharmacies. And that's a lot more, of an even negotiation. And when those negotiations fall through, then you get these stories in the media where the PBMs and the pharmacies have disagreed, and now nobody with CVS insurance can use Walmart pharmacies, and that becomes very problematic for patient care. And so those stories tend not to last very long. I believe the CVS Walmart feud from a couple of years back was only a couple weeks at most before they ironed out the negotiations, and those patients were able to visit those pharmacies again. But the whole negotiating aspect of healthcare is a really intense business, and it's something that leads to a lot of uncertainty for the future of small independent pharmacies. And I think that's why a lot of the negative stories about PBMs come out.
So it sounds like then, and of course, correct me if I'm wrong, because I don't want to be guilty of putting words in your mouth, but the fear from the layperson patient standpoint is that big, conglomerates like CVS Health or Express Scripts could maybe monopolize healthcare in a way that they have so much negotiating power that it leads to, the patients having less choice, and they can't get to decide exactly where they want to go. Maybe they really enjoy their independent pharmacy, and now they can't get their medications covered anymore to go there. And likewise, maybe there's just an underlying fear that, maybe the patient doesn't exactly understand the intricacies behind the screens, but when they know that there's a wealth of negotiating power behind the PBM that their insurance company is kind of working with or is a part of, there's going to be a lot of price setting power, too much price setting power in the eyes of the patient in the hands of the PBM.
Yeah, and I think that price setting is a I don't want to say a fair term, but it's
a dirty word.
It's a dirty word. Yeah, absolutely. And it's anything like price setting goes back to the Sherman Antitrust Act of 18 whatever, and it really has a negative connotation to it, and it absolutely should. Because it really, when you have a monopoly or an oligopoly where there's multiple sellers, if I'm using that term correctly, I'm going back to Econ 102, right? So when you're in that setting where there's very few, very large companies that are kind of controlling the market, you do run the risk of that. But these are very heavily regulated companies, and I think some of the issue that the media has with PBMs in general is related to the ability to sort of set prices and set reimbursement rates at rates that pharmacies find to be unfair. And so this goes back to one of the first things that we were talking about. So if we talk about the different types of prices, there's prices that the wholesalers set, there's prices that the manufacturers set, there's prices that the pharmacy set, but there's also a price that the PBM or the health insurance company sets, and that's something called the maximum allowable charge or the maximum allowable cost, or a MAC price. And so this MAC price is based on supply and demand for generic medications and brands that are available through multiple sources. If you have if you have insurance, that insurance company is likely going to reimburse the pharmacy based on that MAC price. And that MAC price, again, is based on supply and demand. So the PBM or health insurance company will look at all of the available data on how many manufacturers are available and how many claims are being submitted for that medication. And they say, based on that, this drug should cost this much. So they sort of interpret supply and demand and set the price. And in a way, price setting is done in that sense. However, it's not price setting in the sense that they're saying, and I think a lot of small independent pharmacies would disagree with this, is that price setting historically is intended to get people out of business. So like when Standard Oil, the whole thing that led to the Sherman Antitrust Act, when Standard Oil lowered their costs so much that competing companies could not at all survive if they priced their oil at the same cost, then they would basically be on the ropes, and the Standard Oil would come in and buy that company and say, look, you're not going to last, so we're gonna keep our price low until you go out of business or you sell to us. And so Standard Oil kind of became a monopoly by price setting, and that's problematic, right? But that's not what's being done necessarily within healthcare. So these MAC prices are just, from the PBM and health insurance standpoint, they are fair prices based on the amount that the drug should cost. And so it's on to the pharmacies then to buy the drug for less than that cost and, get reimbursed that MAC cost and look to make a profit that way. The problem is that the MAC cost is super low, and it's oftentimes lower than the cost that small independent pharmacies can negotiate with their wholesaler to get. So if we're talking about the other thing that the MAC price does is it standardizes prices across manufacturers. And so if manufacturer A makes, let's say, a drug like metformin for a cost of 5 cents per tablet, and that's what they set their cost at, and then manufacturer B makes metformin, but they set their price at $1 per tablet, then it becomes a logistical nightmare for the health plan and the PBM to understand, how do we make sure that we are paying the appropriate rate. So that's where this sort of MAC price came from, where they said, all right, there's 2 manufacturers making metformin, there's 20 million people who are on the drug. That drug needs to be very expensive because there's a higher demand than there is a supply. On the opposite side, there's 100 manufacturers making a drug that 2 people in the world take. That drug should be incredibly low cost. And so, it doesn't matter if manufacturer B is making it for $1. It should only cost, let's say, 20 cents. And so if that pharmacy buys the drug from the wholesaler at a cost of 20 cents or 25 cents per tablet, great. They are only, 20 cents or less. Great. They're making money on that prescription. But if they get the drug from a wholesaler that contracts with manufacturer B specifically, and they have to pay $1 per tablet, then that pharmacy can't fill that medication because it's going to lose them money. And so the MAC price really tends to be a controversial point, because it's quote unquote fair based on supply and demand, but it's unfair if that pharmacy just can't get it at that cost.
Okay, so let's suppose that the majority of patients, after hearing that and, maybe listening and re-listening to it, because, well, we understand that this conversation can get pretty nuanced, where they're like, okay, it wouldn't make sense if I cast blame solely at the insurance plan or even a PBM, which has an insurance plan under its entity, but I'm adamant on casting blame. Like, who do I point the finger at? Because my grandparents are paying outrageous prices for their medication, and they can't pay for, to treat X or Y disease state.
Sure.
And I think one of the perhaps even more popular entity pointed at to cast blame towards than, say, PBMs is the drug manufacturers, big pharma, as we we hear it defined as. So if they are, the ones making the medication, and they researched and developed it, and it finally goes through all the clinical trials, which is probably not something we'll get into in this conversation because that's a couple-hour conversation in its own right. But it finally hits the market. Maybe for simplicity, we start with something that's a brand name only medication. Of course, they're going to get ridiculed for the price more than something that exists generically. But because it's kind of quote unquote monopolized, because there's legislature, maybe you can quote it verbatim better than I can, but that protects companies from, other companies making that same medication generic. And of course you drive up supply, then the market price decreases because there's a larger supply. But we have legislature that keeps other companies from entering the market with that same medication for, call it maybe 7 years or something, and it can get pushed back even further depending on certain qualifications I'm not sure of off the top of my head.
Yeah, we can talk about that. Yeah.
What leverage does the manufacturer have then in setting the cost that might lead to something that we call price gouging that happened with EpiPens or Daraprim a couple years back?
So I mean, I don't like to place blame. I think the whole system is a problem in itself. And so, there's no easy solution to figuring that out. But, at the end of the day, the pharmaceutical manufacturers, especially in drugs that are brand name only, where they are the only manufacturer, you said, quote unquote, a monopoly. It's, you can take the quotes away. It is a monopoly, right? And it's a purposeful monopoly to protect those research and development costs. And I think it's a, again, whether it's good or bad, you can argue that, but just factually speaking, when a company has a monopoly on a product because of the patents and the exclusivity that are on those medications, it makes perfect sense for them to price the drug at whatever costs they feel is appropriate. So there are cancer medications, for instance, that can cost hundreds of thousands of dollars for treatment, right? And when you think about it and you say, look, these patients are gaining, you know, these patients are gaining life. How do you put a price on that? I think that's one of the hardest things to really conceptualize about this, is that, you want to price your drug at a cost that is profit maximizing, while also, having a, how do I want to say this? While also having a fair price based on the amount of benefit that it's bringing. And so when you consider progression-free survival as an outcome, or you consider, extended life with oncology drugs, that is worth a lot, right? And you can argue that based on certain factors, you might be able to calculate the cost of a life. I don't believe that that's fair, right? I don't think so. I think, if you have a patient that has no family, and you have, and they have, multiple other comorbid conditions that are going to be, also shortening their life expectancy, I think that person has just as long of, or just as valuable a life as the CEO of a major company that, also needs the same drug. So I don't think that that's necessarily fair. And I sort of shy away from those sorts of comparisons. That being said, when you have a drug that in such a competitive space like the oncology landscape, those research and development costs, if that drug was to maintain its position as a first-line therapy for a very extended period of time, that drug can be priced a little bit lower, right? Even if it's bringing all of that benefit, because they have more time to recoup that cost. But what tends to happen is that innovation in certain disease states nowadays is just so rapid that, the first-line therapy for a certain condition, especially oncology, it's not going to be first-line forever. And, there's going to be a large amount of competition, and maybe drugs that are going to beat it in head-to-head competition before the patents expire in many cases. And so when you just strictly look at the cost of a medication and you say, man, that drug is expensive, you have to take into account it's not easy to produce these drugs, especially biologic medications that are, made from living organisms, and require special storage and all of those, sorts of considerations. It's not easy to find new cures for medications, but it seems like with all of the innovation that we have for, drug development these days, drugs are becoming less and less relevant sooner than they historically would have. And so that's why I think we tend to see a lot of very high-priced therapies coming out nowadays, because the manufacturers are recognizing that they need to recoup those costs faster. So when you talk about a monopoly and you have, the patents and the exclusivity on medications, there's two separate protections for new medications as they come onto the market. You have the patents that are granted by the U.S. Patent and Trademark Office. And that is basically like the same organization that will grant you a patent on a new toy. However, the patents on, toys versus drugs are a little bit different, of course. And the patents on a new drug from the date of filing last only 20 years. So what that means is when a new drug is identified in a lab, the manufacturer has a challenging dilemma ahead of them, which is, do we patent the drug now, or do we wait for it to see if it works a little bit in clinical trials first and then patent it? But the longer you delay, the higher the likelihood that somebody is going to knock that off, right? The longer it's the longer it's without protection, the more likely it'll be knocked off. And so that 20-year patent starts from the day the manufacturer takes that patent to the USPTO and asks for it to be patent protected. The other aspect is the exclusivity. And the exclusivity is granted by the FDA upon approval. So,
meaning that no other companies can enter the market with that same medication.
Yeah, exactly. Generally speaking, patents and exclusivities sort of feel like the same thing. There's some nuance behind that patent lawyers that work for pharma would know much better than I do. But basically, they both prohibit other companies from entering the market ultimately. And so exclusivity lasts 5 years for a new chemical entity or a new drug, basically, something that hasn't been on the market before. And so if you have, orphan disease that you're treating, which is a very rare disease state, one that affects less than 200,000 people in the United States, then you get 7 years of exclusivity. And if it's just sort of an extension to an already existing drug on the market, you only get 3 years of exclusivity. And so the patents and the exclusivity run parallel to each other and basically will, they won't add on to each other. So you can't have like 27 years, for instance, but, you are ultimately, the drug is mostly protected until the end of the patents and the exclusivity. Now, it gets much, much, much more complicated because you can patent anything from the drug itself to the dosage delivery form to the specific device that it's being administered in, and all sorts of different things. And you get some added exclusivity if you study the drug in pediatrics. So it gets much more complicated than that. But for that period of time, whether it's the 20 years or the 7 years or the 5 years, whatever the case is, whatever extends out the longest, that that manufacturer has a monopoly on that drug for that period of time and cannot be knocked off legally. Now, there's all sorts of challenges that go along with that. Where one manufacturer will say, "No, I don't think that this patent is actually valid," and so they'll go to court and have all sorts of arguments that impact the likelihood of the drug staying on the market and so forth. But for that time, as you mentioned before, it is a monopoly. And in my humble opinion, while I think it is a very challenging thing to do, is to set a drug price. I can't imagine the difficulty in doing that. The manufacturer has the right to do that at that time and can set it at whatever number they feel is fair.
So if I were to try to package all of that up.
Sorry, I know that was a lot.
Oh, no. I want to, for sure, want to dive into the details of things, which will lead to me right now grossly oversimplifying them. But if I were to try to, I would say something to a patient along the lines of, there's currently government legislation, not saying I agree or disagree with it, that protect that brand name medication from having any other competitors right now. And the natural consequence of that is that they can set that price at whatever they want. And the rationale behind that legislature, from what I understand, is since that manufacturing company did all of the researching and development, pushing it through clinical trials, which I couldn't give you an exact average, but I know is normally in the billions of dollar range.
It could be, yeah.
So they have to, well, maybe not have to, but the rationale behind the legislature is that there should be something in place, some sort of government intervention that allows them to make a profit when you're factoring in all of the millions or billions, however much money they spent in the research and development.
Yeah,
so if I take off that hat and I put on a devil's advocate hat, I would maybe say that we are putting a price on something that is priceless. If we're using or going to the extremity here of oncology drugs and we're talking about a cancer patient, as you said in passing, we can't really put a price on life. And as such, if there's ever a space, an industry space for altruists and saying, hey, look, if there was ever a right time not to prioritize making a profit on something, it's for the benefit of increasing lifespan and quality of life. And, that leads to a whole nother discussion. But I guess my point is maybe there's a logical argument for not having government intervention that protects, other drugs from entering the market. And, by having the free market operate, we drive down the price. And, that the counter argument, I think, would be, well, now there's no sort of incentive for people to research life-saving drugs when they can't possibly be expected to absorb millions or billions of dollars of cost, because they're never going to make any money on it. So they're going to make one drug and go out of business. And would that be kind of the thought progression that goes along those lines?
100%. Yeah, I completely agree. I think, what I was sort of stating was more so the argument for the ability to price set, the medication at whatever cost the manufacturer feels is appropriate. But, there's a whole lot of arguments that can also be made that, any government funded research should be taken into account. And so, if a new medication was identified and was funded by a grant from the NIH, National Institute of Health, for instance, then that money should absolutely be taken into account. If the drug is an existing medication that is being repurposed for something new, it shouldn't necessarily gain as long of a protection in terms of the new indication as as the 3 years of exclusivity would give it. If we consider the benefit of certain medications, I hate to call certain medications out, but one of the most frustrating medications on the market to me is Vimovo, which is a combination of a stomach medicine and a pain reliever. Both of those medications are available over the counter at a combined cost of probably less than $1 a day. And if you look at a 30-day supply of that medication, Vimovo, and there's another one, Duexis, that's the same situation, the 30-day supply of that combination medication is over $2,000 a month. I mean, it's unbelievable, and it should not be the case. And so while that patent is protecting Vimovo, that drug is not really doing anything that the existing medications can't do itself, but it offers patients a once daily medication versus a combo medication versus a medication that they would have to take two separate pills for. I mean, this is ridiculous to me that could cost that much money. And so, there's all sorts of arguments that can be made for recouping research and development costs and all of that, but there's also certain outliers within the industry that I feel are really going to continue to keep it in a negative light. And I think the one thing that is also problematic, and we have sort of a very unique health system in the United States compared to other countries that have more socialized medicine. But I think that a lot of manufacturers use the profits that they make within the healthcare system that we have to make up for lower costs elsewhere in the world. And there's all sorts of examples of medications costing very little elsewhere in the world and costing very unreasonable amounts here. And I would say that's basically related to the fact that insurance covers most of these costs, and patients don't really feel the true cost of medications. And there's a whole bunch of different rabbit holes we can get down into with this, but one that I found very interesting was when there was some legislation that supported the price of medications being included on television advertisements. Like, what is that actually doing? It's just highlighting which cost is it going to be included? Is it going to be the manufacturer's cost? Is it going to be the cost that the patient actually pays at the pharmacy, which could be a little bit higher than that based on all the middlemen, as we talked about previously? It could be significantly lower based on the fact that most patients have insurance. So, I mean, all of these different aspects play into pharmaceutical drug pricing, and it's an incredibly difficult conversation to have, just given all of the nuances. But yeah, I think there's arguments to be made both for and against, those patents. And I think the biggest argument that is continuously made is the one that you highlighted, which is, is it actually the money? Are the pharmaceutical manufacturers actually recouping drug-related, research-related costs for new drugs? And that's not a question I have an answer to, unfortunately. But it's the argument that is very commonly made. And to go back to your number, new drug development could cost, based on some numbers that I remember citing in the past, between $400 million and $4 billion, depending on how many times a drug fails in clinical trials, and how well run the clinical trials are, how large they are, how many sites they include, the amount of time that this takes, the amount of people working on the research. I mean, there's all sorts of factors that play into it, and that will potentially impact the end cost of that medication too.
Yeah, I know you said that you don't have the right answer, and if you don't have the right answer, I certainly don't. But something that this allows us to segue into is what has been a proposed answer to reducing these medication costs for patients and overall healthcare costs that has been pushed more so by like a liberal leftist agenda in recent years that I kind of want to deconstruct here. And that is the idea of universal healthcare. So we have the election year coming up, and we know that Bernie Sanders has got a lot of publicity over, promising a free government provided universal healthcare. Could you talk a little bit about what that would look like in practice? As from my understanding, I kind of associate that with what you referred to as a more socialist or socialized healthcare system, and the pros and cons of doing something like that. I think the obvious pro is if it were to work out and that all the costs were to be absorbed, the obvious pro is much lower cost for healthcare, at least at face value, that they see on their hospital bill or their pharmacy bill for patients.
Yeah, so I think this is a very timely question, as you mentioned. I think that one of the challenges with this, though, is that there's just so many ideas as to what it could potentially look like, and all of the potential costs associated with it, and so forth. And I think the whole pandemic that we're in right now is sort of, making that discussion a little bit more interesting, because a lot of health insurers right now for the pandemic are waiving inpatient costs related to the infection. And so if a patient were to get sick and have to go into the hospital, they don't have to worry about the cost of doing that. And this is one of those things where it's really going to test our system. And with all of the stimulus money that has already been churned out, all of the additional money that's going to continue to be churned out, if we were on a single payer system, I really think that it would be pushing it even further, the national health expenditures on healthcare. I think it would have been a very different conversation if we had a socialized medicine approach prior to this. For better or for worse, I have no idea. It's just in general, it would be a very difficult or very different conversation. So what it could potentially look like, I mean, based on things that were discussed, right now we have Medicare, for instance. Let's just take Medicare as a program by itself. That is a very socialized sort of medicine where, elderly individuals, anybody over the age of 65, if they don't have other coverage, is eligible for and is automatically enrolled into Medicare Part A, which covers your hospitalizations and so forth, and they have to opt out of Medicare Part B, which is your like your outpatient services and so forth. So doctor visits and screenings and all that. So if we look at it from the perspective of how well Medicare is working, there's a lot of good things that are going on with it. However, it's not a solely government-run program. It's government funded, but health plan administered. So
Right.
I'm trying to be very careful about the words. So health plans, insurance companies, are the ones who are making a lot of decisions about what's covered, what's not, what patient copays are, and all of that. And so there is a form of Medicare called Original Medicare that is solely run by the government. It's much less popular nowadays than it originally was, just because it's less efficient, frankly. Anything government run, and I don't believe that this is a hot take, but anything government run tends to work a little bit less efficiently than if the government wasn't involved in it, right? There's a lot of red tape, a lot of bureaucracy, and it leads to delays in all sorts of different aspects of it. And so original Medicare, while it has its pros, patients can go to whatever hospital they want, they can, go to whatever doctor they want, and so forth. It also has its cons that, there's no out-of-pocket maximums. Major expenditures can end up costing patients significant out-of-pocket amounts. It just doesn't flow as well as, health plan administered benefits, which, exactly where to go. Well, ideally, you would know exactly where to go, and you have an idea of what your copays are going to be. You have an idea that you're not going to pay anything more than, let's say, $6,500 out of your own pocket throughout the year, and so forth. Now, health insurance companies and this is not just because of pharmacy benefit managers, just in general, it's just a very complicated industry that leaves a lot of questions for patients. And so there's pros and cons to having a completely government-run system, and there's pros and cons to having the system that we have now, which is, again, government-funded, where there's aspects of the program that are government-funded and health plan administered. So that all being said, there's different approaches that every country in the world takes, and some of them include expanding health benefits for everybody. And so how do you pay for something like that? And again, there's a lot of different solutions. You can increase taxes on everybody. You can raise the cost of care for everybody, and that way, if I go in to the hospital for, let's say, an appendectomy, I'm paying significantly more than I otherwise would have, but I'm paying significantly less than I otherwise would have, but it's because when you go to the doctor for a sore throat, you pay a lot more than you otherwise would have. So, the subsidized version of that helps to kind of understand how things would be paid for. An example, when I was a student, actually, on my API rotation, I went to the UK for a rotation. And one of the things that I learned there was that on their healthcare system, it doesn't matter if you're picking up one tablet of, the cheapest drug on the market, let's say Tylenol, acetaminophen, and, you go into the pharmacy and you pick that up, it's going to cost you basically the equivalent at the time of about $15. Versus if you pick up, a 12-week course of the most expensive drug on the market, let's use Hep C as an example, you go into the pharmacy, get your 12-week course, it'll cost you $15. So it doesn't matter what you're getting, you're paying the same amount, and it's because the people who are filling the very inexpensive medications are helping to subsidize the cost of those who are filling very expensive medications. And, whether you agree with that, whether you don't, that's, up for debate, but that is just one proposed way that certain countries do it to help pay for it. So how we do it specifically in the United States is going to be, so first off, if we do it in the United States, and how we do it in the United States is really up for debate, because there were, discussions, expand Medicare, the program that is working well enough for the elderly, much of the elderly, not necessarily everybody, and you expand that to everybody 18 years and older, and everybody 18 and younger is on Medicaid or a similar program to that. If you look to like other countries, are just using the UK as an example, if you have private insurance and you can afford private insurance, which tends to get very expensive once people start backing out and going to the government option, then you can keep that if you want. And that's something that potentially, was discussed, as part of all of these democratic debates as they were continuing on. So I will, again, completely refrain from the political side of the discussion, just to maintain my wide audience base. But I think the important aspect of it is that if it's done, it can't be like a haphazard sort of, let's just expand it to everybody, because it needs to really be methodical. It needs to be carefully planned out, and it really has to, not end up costing the health system significantly more than what we're paying right now. Otherwise, why did we do it in the first place?
Right. So let me think here. maybe I'll die on my shield by saying this, and I'm speaking entirely for my own political views and not yours, which, as I had brought up multiple times on this podcast, even though if I took the constellation of all the political spectrums, we'll say political arguments, of which there's a spectrum if you're going to be right leaning or left leaning, I'm pretty consistently in the middle, but not necessarily because I fall in the middle on all those arguments, just because they kind of average out to being somewhere in the middle. That being said, economically, over the past 4 or 5 years, since I kind of had my own time to think about it and gather information, me personally, I think I have felt pretty right leaning in that I think more often than not, a free market is best for everyone as opposed to government intervention. Again, my political views, not yours, Dr. Kheloussi, but I'm willing to die on my shield here. So with that being said, and you did touch on this being a possible argument being brought up by people in passing in your answer there, and that is by putting something like healthcare into the hands of a, by default, bureaucracy, then there's a possible slowing of giving care. And even though we are maybe helping a lot of people out, which I would agree with, would help a lot of people out to have, say, for example, a $15 set copay on all medications, and patients with Hep C can get their Harvoni for $15 and, not $100,000. I think that's good. I would have trouble arguing against that. But what I don't think is good as the high likelihood for medical procedures, elective or otherwise, taking people however long. I've heard the horror stories, and I don't want to put an exact statistic to it, so take this with a grain of salt, everyone listening, of maybe taking upwards of a year or several months on average for quote unquote life-saving surgeries or life-preserving surgeries in places like Canada or other socialist nations over in Europe. And I think that's what scares me most, because it's hard to put a price on those things. And I think that's why keeping a free market and having a government-funded but health plan, distributed, maybe that's not the best word, but that's how I conceptualize it, healthcare system works a lot better in terms of time to patient care. And time is one of those priceless things to me that I think that the time it takes for people to get seen by a doctor or have a life-saving procedure is something that might need to be talked about a little bit more in this argument than the attention that I think it has received.
Yeah, no, I completely agree. And I think that's one of the biggest arguments against socialized medicine and the single payer system, is that the delays to care, even if it's not a life-saving, surgery or whatever the case is, if you're talking about something like a hip replacement, where it's the hip is leading to significant amounts of pain and the patient needs to get a replacement, like, again, I don't know specific statistics, but the wait time in some European countries is several years to get a hip replacement. And so that is problematic, right? Because at a certain point, if a patient is needing even what doesn't seem to be a life-saving surgery, it could lead to mobility issues. It could lead to falls and all sorts of additional complications that would not have otherwise happened. And so the time to care is a big argument against socialized medicine, but I've heard the counter argument as well, that a lot of the time to care issues in the United States don't necessarily come up as much because people are foregoing care. So, they say, well, I don't want to pay my copay to go to the doctor, so I'm just gonna, tough out this cold that I have and not, and then it turns out to be pneumonia, and then it becomes a bigger issue, right? So, the time to care is an issue, but also sort of the foregoing care because of the unaffordability of it is often an issue that also needs to be discussed too.
Yeah, that does make sense. If I were to take a step back and say, I don't have the answer of whether or not a universal healthcare system would be, more good than bad or more bad than good, because we didn't put it into practice. That being said, I think a lot of people would agree that our U.S. healthcare system is far from perfect. I know we're tiptoeing into speculative territory here, but so I don't want to put any words in your mouth or force you into saying, like, this is definitively the right answer that will help everyone. But if you were to speculate what proposed solutions should be talked about more often, no matter how big or small, is there anything that comes to your mind with how we could make our U.S. healthcare system a little less costly while keeping it as, if not more, efficient?
That is a very difficult question, and
For sure.
purely speculative, right? I mean, we have ideas that have been sort of shared, and I think if you, instead of speculating on what could lower costs, what could improve the system would be a better discussion to have. And I think the biggest thing is surprise hospital billing. I brought this up earlier. I think this is such an issue right now that when you go to a doctor, you don't know how much you're paying. And every time I go to the doctor, I always ask, just to kind of hear it again, because I think it's so ridiculous. When I sign the waiver that says I can be billed, for the outpatient, cost because the visit I'm going to is associated with a hospital. First off, crazy. But I always ask, I'm like, all right, I'm happy to sign this, but how much am I going to have to pay? Do you have any idea what that would be? And they always say, no, I don't know. And I'm like, all right, so I could be signing right now to accept charges in the thousands of dollars just because your outpatient office is connected to a hospital. I mean, that's insane to me. And so, I've heard stories from other people that they would get a bill of $500 and it's solely a facility charge. And they're like, what is this? I never even saw, I didn't even know this was a thing. And so after I called my insurance one time and I said, do you know how much this charge is going to be? Because I wanted to know in advance so I could start saving up for it, because that's what you need to do with healthcare. And they said, no, I have no idea. I said, as the insurance, you don't know how much I could be billed by you. And they said, well, it's because we haven't been billed yet. I said, all right, well, then who do I talk to? And they said, well, you should call the billing office of the hospital. So I called the billing office of the hospital, and they said, we don't know. And I said, how is this even possible that individuals, who are the most educated people, with my benefits, and I've worked in insurance for my whole professional career, and I like to think that I know a thing or two, but I still felt completely clueless. So surprise billing that has to go. Like we as a society should not, this is embarrassing, I think, as a society that this exists. It leads to all sorts of medical debt that, patients carry around for years and years. And it's just, it hurts their credit scores and all sorts of different things. So I think that, that's the major issue. The other aspect is, keeping patients in touch with the cost of care is very important. That's not to say that patients should be charged more for healthcare or anything like that, but flexible spending accounts or health savings accounts really sort of get people to think twice about utilizing resources. And so one of the first things I talk about in my elective, that I'm a little disappointed you never opted to take that class. But one of the first things that I talk about is moral hazard, which is that when people have insurance, they tend to live a riskier life, because if they are going to be injured or they're going to get sick or something like that, they don't have to worry about the financial burden that brings. The insurance company is going to. And so more insurance actually ends up leading to more healthcare utilization. And this is a proven thing in studies. And so what I found most interesting about this is that when you say to patients, look, we will cover you in the event of catastrophic costs. And the insurance will cover you in the event of very high healthcare costs. But you are responsible for the first, let's say $1,000 or $2,000. This is something called high deductible health plans, right? With appropriate planning, and I don't think, again, I don't intend for this to be a hot take, but with appropriate planning, most people can save $1,000 as an emergency fund for to pay that deductible, right? And so if you have that $1,000 in the bank and you're ready to go, that says, as soon as I spend this $1,000, the insurance picks up the rest, that is going to make you think twice about spending that first dollar on healthcare. And you're not going to, take a, what's the word I'm looking for? An unnecessary medical procedure or, something like that. Now, the problem again, I should, put an asterisk by this, that people will make poor decisions when they don't have all of the information. And so in healthcare, many people don't have all of the information to make an educated decision on their health. They don't know what their MRI results mean. So they don't know if they should follow up with a specialist. They don't know what symptoms they're having, if it's a life or death situation, or if it's maybe just like some acid reflux. Acid reflux and heart attacks really often, get mistaken for each other. And so if somebody says, yeah, you know what, I think it's just a little acid reflux, I'm not going to go to the hospital, I'm not going to call the doctor because I don't want to spend that first healthcare dollar out of my bank account. You know what I mean? So, if we can somehow link, patients to the cost of care by keeping them in touch with a small amount upfront that is affordable for them, but then healthcare or health insurance kicks in and covers, catastrophic costs after that point, then it'll lead to less healthcare utilization, healthcare costs will go down, and that will solve a lot of our problems. The last thing is high healthcare costs associated with pharmaceutical medications. And this is a very behind the scenes sort of thing, but there's something called contracting or rebating within healthcare, where pharmacy benefit managers, another one of the very important roles that they have, is they will often negotiate lower costs on medications for prescriptions for health insurance companies. And so these lower costs will then lead to certain medications being preferred and lower costs for patients in the long run. Now, I should take a step back and say that will lead to lower costs for insured patients in the long run. But people who are not insured or who have very high deductible health plans that they can't afford that first $1,000 or $2,000, they are facing often the full cost of the medication, which ultimately rises because of the existence of these contracts. So while, the system that we have right now, it would be completely unsustainable without these rebates and these contracts. If we were to switch to a single payer system, I don't know if you heard in the media or anything, that one of the plans was that single payer would then be a single point of manufacturer contracting. And therefore we would be able to get lower prices on medications. Well, all that would end up doing is leading to higher prescription drug costs, and it would end up kind of messing up our system a little bit worse in some ways. So I think, those three methods, those three things that we have right now should really be a target of something that can be fixed in the future.
Yeah, at face value, as I hear you talk about it, all of those make sense to start advocating for and towards. I do want to be very respectful of your time, because I know we've been going at for about an hour and 20 minutes now, and I think there's been a lot of knowledge to unpack, but there's one last mini segment that I kind of want to go into here, and that is, beyond talking about possible problems, the counter arguments, and proposed solutions, I think almost everyone would agree we can't snap our fingers and fix it right away. So for the patients, which is virtually everyone listening to this, that can't snap their fingers and make the changes to U.S. healthcare that they want to see right away, what, say, however many points you want to give, I'm thinking in my head maybe 2 to 5 quick points that you would think of if they're like, hey, I'm looking to optimize my health insurance plan. I'm willing to bounce around to different plans. I can, afford some sort of private insurance. What questions would you be asking, or what things would you be looking for, or what modalities would you use to help optimize a patient's healthcare, their whole healthcare, the efficiency of care that they receive, the safety of, fill in the blank procedures or medications, and
Sure.
of course the cost that they have to pay?
That's a tough one. That's a very tough question, and it's one that I think is incredibly important. And I'm happy to take a stab at it. But there's far too many things to consider that we have time to talk about today. But I
Right.
would say, the wide range of 2 to 5 points, if I can come up with them here, I would suggest first off understanding how much you can pay. So we have a real problem in this country with individuals carrying large loads of debt, whether it's student debt, credit card debt, car loans, etc. Um, and so understanding personal finance it seems unrelated, but it's absolutely imperative that you don't purchase too much insurance that you then strap yourself from paying for other things, but also strap yourself from saving, because even the best advice on a health plan that you could ever receive will not tell you what a procedure is going to cost, because it comes back to one of the first things that we talked about, which are all those contracts. So, if you end up going to hospital A versus hospital B for a procedure, it might cost you a significantly large difference between the cost of that procedure and the amount that you're expected to pay, because it's based on typically percentages of the cost. So if your health insurance company has negotiated a very favorable rate with that hospital, then you'll pay a little bit less. And if they didn't, then you'll pay more. So I can't, when you sign up for insurance and you say, how much am I going to pay if I have a heart attack and I go to hospital A? The insurance is, they might be able to quote you a number, but that's going to change based on contracts. It's going to change based on, the cost of the supplies at the hospital and so forth, depending how the contracts are negotiated and so forth. So the best advice that you can receive is still not going to tell you how much you're going to owe if something were to happen. On top of that, nobody knows what's going to happen, right? And that's why insurance exists. So whatever health insurance you can afford, make sure that it's covering the services that you use regularly right now. So if you take, let's say, 5 medications, make sure that all 5 of those medications are covered by that insurance. If you have a routine follow-up appointment with a specialist, find out who the specialists are, and if you want to stay with the same one, make sure that that person is quote unquote in network. And you'll get an idea of how much it'll cost to go to that person. If you are if you're buying too much insurance and you can't save up, when you need that new medication that is not covered by your insurance, or you go to a specialist who is not one that you usually see, you're going to have costs that you weren't expecting, and it's really important to have that money kind of pushed aside in your bank account, saved for a rainy day. A lot of financial gurus call it a emergency fund, for instance, or a slush fund for health expenditures. So, having that, not over purchasing insurance is very important, because even the most expensive plans will not necessarily cover every circumstance. So it's a very foreign language to go through all of those documents that are sent. And you have, advocates available to you. So third-party insurance brokers will be able to kind of explain things a little bit more than if you were to buy directly from a health plan. If you were to, now keep in mind, they all work for commissions based on whatever plans they sell, so they have a little bit of a conflict of interest, but they also can explain things a lot more or a lot less conflict of interesty than some of the, if you're buying directly from a plan who wants to sell you on their specific plans. There are, if you're buying an Affordable Care Act plan, that means one that, is not through your insurance and it's not through a government program like Medicare or Medicaid. And you buy that on the healthcare.gov website. A lot of local hospitals will have what are called health navigators that you can work with. And those individuals, their job is specifically to help you find a plan that works for you. So making sure that you're not going into this alone is extra important. Ask people who do this for a living that are going to have as little as a conflict of interest as possible. I think that's probably the best advice that I can give. But Just make sure that the co-pays and the co-insurances, which are basically percentages of the cost, make sure that those amounts are affordable to you, and the amount that you pay every month is also affordable to you, to allow you to kind of save up in case an unexpected cost arises.
Yeah, I think that's really good, tangible advice, and something that I will probably be back here re-listening to the advice you gave, as I'm coming out of college here a year from now, and will be seeking out my own health insurance plans. So again, thank you very, very much for your time. There was a lot of insight in here, some naturally information heavy insight in here that I, for one, will have to re-listen to make sure I get all of the nuanced details out of, and I hope some listeners do the same. Before we get going here, is there any sort of shameless plugs you have, like social media following or anything like that you want to put out into the world?
You know what? I have social media anxiety, where posting things online makes me very uncomfortable. So nothing really to shamelessly plug here, unfortunately.
Hey, no worries.
I appreciate the opportunity.
I always want to give you the platform and the platform, if at all possible. So thank you again for your time. It was great talking to you, Dr. Kheloussi.
Yeah, it's been my pleasure. I really appreciate you having me.
Alright everyone, thank you all for tuning in. Please track us down on social media. Our Facebook is Insights of All Trades. Our Instagram is at Insights of All Trades. Our Twitter is at IOAT Podcast. And you can find us on Gmail. It is insightsofalltrades@gmail.com. So please just send us in your insights. It would mean a lot to us and a lot to everyone else. Meaning, send in any tips or tricks you've learned through your trade or your passion that you think everyone would benefit from knowing. So until next time, adios.